Hi, I'm Dr. Henry Dimano. I'm an orthopedic surgeon here at Mundo Medical Center, and for today we are going to discuss about adolescent idiopathic scoliosis. The general definition of which is that if you look at the person's spine from the back or from the front, you will notice a curvature. Typically, patients or people will have a straight appearing spine if you look at them from the back or from the front. Scoliosis means that there is a curvature of the spine. Usually we see scoliosis as doctors when patients come in, or normally when the parents bring their patients in, because majority of the patients are going to be young teens or maybe mid-teens. The presentation is typically asymmetry of the patient. The parent or even maybe the child notices that her body or his body is no longer straight. As of now, we have found no way to prevent it. We can't actually predict who will get it. All we know is that about 4% of the population will probably present with it. There is no way to screen for it very early in life. It will present normally during the teenage years, and once it presents, the bigger question would be, will it get worse and can I fix it, or does it need to be fixed as the patient ages? Majority of patients presenting with idiopathic scoliosis are basically going to present with right-sided curves. If the curvature is left, we try and see whether there are other reasons for the scoliosis. It might not be idiopathic scoliosis. There might be some other underlying cause which may be fixable or which may need a different line of treatment or management. But for the most part, scoliotic adolescents will present with a right-sided curve that you can measure when you make them bend forward and when you make them stand straight. Now, we confirm it and we quantify the scoliosis by means of an X-ray. We take a patient's X-ray, a spine X-ray, preferably a whole spine X-ray, and we measure what is known as Cobb angle. Cobb angle is measured by referencing the top of the curve, the most tilted part of the top of the curve, and the most tilted part of the bottom of the curve, which creates the angle. And we try and measure this angle year after year, or sometimes even twice a year, to see whether it's progressing or not. We also make the patient bend sideways, left and right, and take X-rays because we want to see whether the curve is flexible, whether it will uncurve a bit when you bend on the convex side, and whether it will become even more curved when you bend on the concave side. There are several ways of assessing skeletal maturity using different bones of the body, but one quick way of doing it is by looking at the pelvis, the top of the hips of the patient, because there are growth centers there for bone that give us an idea how old the patient is in terms of the skeletal maturity. Not the chronologic age, but the skeletal maturity of the patient. We have a grading system known as research staging. So this is stages 1 to 4 for the iliac crest, for the hips of the patient. Stage 5 is adult. Stages 1 to 4 are the different stages of maturity. So immature is typically stage 1 to 3. And 4 and 5 are considered skeletally mature or adult. Now, what this corresponds to is growth in height. Patients who are growing very fast, normally in their early teens, will tend to have lower research stagings. Also, the development of the curve is usually faster when the patient is growing faster. So the growth of the curve becomes more evident usually in the early adolescent years when the patient is still skeletally immature, rather than when the patient is already about to stop growing in height, coming into the 20s. Into the late teens. So we want to be able to, number one, measure how big the angle is using an X-ray, using Cobb angle measurement. And number two, we want to know how old the patient is at the time you took this measurement, the Cobb angle. Because typically, patients who are younger will probably present with more progression of the curve. And patients with a large curve to begin with will typically progress more. Okay. So we want the curvature to stop progressing. If we can reverse the curvature a bit, make it smaller, all the better. If it's achievable to totally straighten it, yes, but normally that's not the expectation. So that is where surgery comes in. And ideally, we want to do surgery closer to when the patient is already slowing down in terms of in height. It's a lot trickier to do scoliosis correction or to stop the progression of scoliosis in a younger patient because the bones are still maturing. So we would normally wait until the patient is a bit older, and as long as the curvature is not so bad, and then we discuss the possibility of doing surgery. Now the good news is only about 1 out of 10 patients with scoliosis, only 1 out of 10 teenagers who present with scoliosis will actually require surgery. So majority of them will exist through life with a curve less than 30 degrees, but maybe greater than 10 degrees, and this will be their curve for the rest of their lives, and they can live normal lives with it. It's not going to be a cause of concern in the future. So there are specific ranges at which we might want to be more aggressive in surveilling or tracking patients. This is the 30 to 50 degrees range, and of course in those greater than 50 degrees, we might want to consider doing scheduling surgery or entertaining the possibility of surgery whenever the patient is ready for it. So those are the basic treatments. So you either observe, you brace, or you operate on a patient. So the 3 O's: observation, orthotics, what we call braces, or operations that involve implants in patients' spines. So I hope that has shed some light on adolescent idiopathic scoliosis. Again, I'm Dr. Henry Di Maano here at the FDMMC Medical Center. Safe at alaga kayo dito sa FDMMC Medical Center.